Alrighty, y'all. Let's try this a third time. Give me just a second, and I'm going to pull this up for y'all to see. Alrighty. Here we go. Good evening, everyone. Welcome to our Life in Motion monthly webinar series. I'm Caitlin, and tonight we have with us Dr. Cardenas and Bonnie. To introduce Dr. Cardenas, he's an accomplished third-generation neurosurgeon specializing in minimally invasive techniques for complex spine issues, having spent much of his career right here in Memphis. After graduating from Christian Brothers University, Dr. Cardenas earned his medical degree at Meharry Medical College in Nashville, followed by a surgical internship at the Medical University of South Carolina in Charleston. He then went on to complete his neurological surgery residency at LSU Health Science Center and served as chief resident for the neurological surgery service from 2007 to 2010. Then that was followed by a minimally invasive and complex spine fellowship in Memphis, Tennessee, here at UT Health Science Center. Now to introduce our special guest with us, Bonnie. Bonnie works with Dr. Cardenas at OrthoSouth clinics in Arlington, East Memphis, Germantown, and South Haven. She's a board-certified advanced practice nurse with over 17 years of RN experience in both the hospital and clinic settings, including 10 years of specialty experience in neurosurgery. This evening, Dr. Cardenas and Bonnie will cover the facts, the myths, and the realistic expectations surrounding treatments with stem cells. Throughout the webinar, Dr. Cardenas and Bonnie will be asking you some questions, and you can ask them questions as well. If they ask you questions, it's totally okay if they're wrong. I'll share a few of your responses out loud, and then they'll reveal the correct answer. As always, feel free to submit your questions in the comments throughout the webinar. So without further ado, we will turn it over to you, Dr. Cardenas and Bonnie.
Great. Thank you so much, Caitlin. So I have a little presentation already, and thank you, Bonnie, for being here. I have a very brief presentation here prepared. We'll go through back pain, its treatments, what causes back pain, and also emerging trends in stem cell therapy for low back pain. And if we follow the our stem cells and how are they used for the treatment of low back pain. We know that low back pain is one of the plagues of modern society. It affects about 12 to 30% of U.S. adults at any given time. So that's its point prevalence. And the Global Burden of Disease Study in 2010 estimated that low back pain is among the top 10 diseases and injuries that account for the highest number of disability-adjusted life years worldwide. So what does that mean? That people basically secondary to back pain, it's one of the top 10 situations that get them out of work. Because of that, the annual expenditure to treat low back pain in both direct and indirect costs is estimated to be over $100 billion. So it's a significant burden on the economy and the patients dealing with chronic low back pain. So what causes back pain, right? Low back pain can be caused by a myriad of things, right? We have a lot of structures in the spine. And one of them, the one we're going to focus on today, is the intervertebral disc. The intervertebral disc, just like anything else, has some parts to it. We have that The annulus fibrosus is the surrounding part, right? You can see this purple structure around the green one, and the green one's called the nucleus pulposus. The annulus fibrosus is what keeps that more of a watery gel substance, nucleus pulposus, inside, right? It's made, the annulus fibrosus itself is made of collagen sheets, which are called the lamella, right? They're interwoven, kind of like a knitted sweater or some structure like that. These lamella are held together with molecules called proteoglycans, which is kind of like glue, and is the surrounding portion of the disc, like we said. The makeup of this structure is very similar to what the nucleus pulposus is. It's about 65% water. We have both types of collagen, type 1 and type 2. We have proteoglycans making out about 20% of the dry weight, and about 10% of the annulus also contains elastic fibers. And those are seen where the annulus attaches to the bone. The lamellar design is that the collagen fibers that make up each lamella run parallel at a 65-degree angle. So they go crisscross to each other, trying to hold the nucleus inside. Again, because each lamella is flipped in the opposite direction to the previous one, and it's alternating, it greatly increases the shear strength of the annulus. And so we have this at every single inner space. The part that's inside is called the nucleus pulposus, and it's a hydrated gelatinous substance that is made up mostly of water. This is about 80% water. Its solid dry component makeup are proteoglycan, which is 65%, type 2 collagen, and a small amount of elastin fibers. Collectively, the proteoglycans and the collagen are called the nuclear matrix. The cells of the disc, which produce the water holding proteoglycan molecules, are very similar to chondrocytes. Chondrocytes are the cells that are seen in cartilage. And there are also other cells inside the nucleus that we'll talk about later on in the presentation. The proteoglycans are found in several structural forms within the disc, but the one that's most important is called aggrecan. And the reason why they're important is because they trap water and they can hold about 500 times their weight in water. So they're pretty sturdy molecules that give us that gelatinous, most of the gelatinous composition of the disc. So you have that these structures, the disc has these structures that form it. So what happens to it, and why do people get back pain? Again, the degeneration happens, and it's called degenerative disc disease. This happens as we age, right? Why do discs degenerate? It's just basically inflammation, right? We have inflammation will cause the structural changes within the disc, and these will be the loss of hydration, right? The decrease in the cell volume, and the diminished extracellular matrix molecules. So this happens as we age, or it can happen early, secondary to genetic factors and environmental factors as well. These degenerative changes obviously are going to contribute to the disc tissue becoming less functional, right? And as it becomes less functional, it can result in a volume decrease in the intervertebral disc, and then this can lead to pain and disability.
So beyond the disc itself, what would you say the broader consequences of degenerative disc diseases?
So again, I think the consequence is pain, and societally we have to think about these patients becoming riddled with these issues and not being able to perform their job. So to us, it's very important to try to treat these patients and to get them back to working pain-free. Again, sometimes because the degeneration can be very severe. The treatment modalities can be very frustrating, and patients sometimes don't do great when they have just degenerative disc disease. Again, the pain associated with symptomatic degenerative disc disease can have significant short and long-term consequences, right? Like I was saying, there's broad and highly specific social, physical, and economic impacts. The degeneration of the disc, not only can it impair an individual's ability to perform simple self-care activities and preclude them from enjoying leisure activities, but can also prevent them from working and contributing meaningfully to society. So economically, this can be a real burden. Physically, within the disc, the structural changes that result in abnormal mechanical and biological pathological processes lead to the pain, right? The reason why the degeneration happens is because, again, the cells inside the matrix start dying as we age because of environmental factors. Again, depends what you do for work. If you're working in a very sort of hostile environment, you're going to degenerate a lot faster than somebody that isn't working in such an environment. Or if you're sitting down for long periods of time, if you're obese, all of these things sort of contribute to the back pain. But because we have the eventual decrease in the cell population, this will lead also to facet arthritis, or the joint arthritis in the spine. It'll lead to bone spur formation. It can lead to spinal canal stenosis. It can lead to slippage of the spine or spondylolisthesis. So, the degeneration of the disc is eventually going to lead, or it can lead to some of these other issues that will also cause pain. Mm-hmm. So, how do discs degenerate? Like I said, people age, and obviously some of these cell lines that live within the disc start to become more scarce, but also inflammation happens, right? The degenerated discs are characterized by the upregulation of inflammatory cytokines. Fancy names of these molecules like interleukins and tumor necrosis factor alpha. These are all pro-inflammatory molecules. And when you have a hostile environment, like, for example, you work with jackhammers all day or something of that nature, can lead to higher insult frequency, and therefore more inflammatory response with these molecules. And when these molecules get secreted, this leads to further tissue breakdown and pain. The breakdown of tissue within the disc is due to basically the depleted capacity of the local cells to produce new cells. And so again, the inflammation itself can kill some of these cells that produce all of the disc contents, and it'll cause an imbalance in between the production and the breakdown of this substance, right? And so the disc itself is a very hostile environment. We don't have giant blood vessels feeding it. For example, like, you have your kidney's supplied by this giant artery called the renal artery, and so it's never really lacking in any blood. So the blood flow happens there. The cells inside the kidney get the oxygen they need, and they can live as long as you do. And the breakdown of those cells is not as facile as when the cells break down inside the disc, because the disc itself, like I said, is a hostile environment. It doesn't have blood vessels that supply it with oxygen and nutrients. It's subjected to highly mechanical forces, right? Every time we stand up, every time we walk, those forces continuously press on the disc itself. And again, it's low in oxygen, right? The composition of the disc space in there is low in oxygen. So over time, right, these changes can result in global tissue and structural damage, right? And again, this is manifested by acute chronic pain and may eventually result in structural failure. Like we said, people can develop herniated discs, stenosis, spondylolisthesis, all these things that they are amenable to surgery, but this is not.
So what treatments would you say are for people with degenerative disc, low back pain? Is surgery an option? Where does it fall in line?
Well, so current treatment options for symptomatic degenerative disc disease in the early stages is limited, right? There's that type of patient that will have a lot of back pain, but not too much spine degeneration. For example, they won't have any stenosis, they won't have any disc herniations, they won't have any spondylolisthesis or any of these other problems that are fixed with surgery. And so the treatment for these patients is very limited, and it can be very frustrating for them because they come to see the spine surgeon, the spine guy, to see, it's like, what can I do about my back pain? This guy needs to fix it. So there's something to fix. Sometimes, unfortunately, there isn't something we can focus on surgically. And so we can try medications, we can try physical therapy, we can try pain management like epidural steroid injections, acupuncture, chiropractic care is great sometimes, and other non-surgical modalities. People sometimes respond well to needling, for example, or cupping, or massage therapy, or aqua therapy. And so we try all of these modalities with our patients. But again, some of these patients, their disease will progress to more advanced stages, and it becomes unresponsive to these types of interventions, right? And it remains clinically debilitating for the patient. And then if, like I was saying earlier, if you have a surgical lesion in there, it may be a very easy decision to proceed with an operation that's gonna basically take care of that one problem that may be causing some of this other stuff. But the surgeries themselves, the surgery itself for low back pain is very controversial. For discogenic pain, it's very controversial. We don't know if the patient, or how the patient is going to do. They have a lot of opinions. There's a lot of opinions across the board. Some people think that you confuse patients when they come in for back pain. Fusion means, putting screws and rods and doing all of these things in the spine. And some people don't. They think that some people think that it's okay to start treating patients with fusions after they fail all conservative management, and some people are not necessarily too convinced. And again, there's two whole sets of data on that. Again, this is just an example. These pictures are an example of what a fusion is, right? And these are performed minimally invasively. The patient is completely asleep, and it's a long recovery process. It takes anywhere from 3 to 6 months for the patient to start feeling better. So does it work? Does surgery work? Again, like I was saying, it works very well when patients have like a herniated disc or stenosis, or they have that slippage that's called spondylolisthesis. But surgery for chronic back pain is controversial, right? The results are mixed. That's why it's controversial. We have a couple of societies in neurosurgery, the American Association of Neurological Surgeons and the Congress of Neurological Surgeons, or AANS and CNS for short. They recommend fusion as a treatment alternative for patients with 1 or 2 level degenerative disc disease after all of the conservative methods have failed. But again, even though you have improvements in low back pain scores immediately, right, with patient satisfaction scores at around 70%, the fusion surgery shows little long-term benefit when compared to non-operative management for chronic low back pain. In other words, at 5, 10 years after the surgery, basically the patient seems to be more or less the same as they were before. And so if you're going to be the same, then why have the operation if only about 60 to 70% of the people will do well? Again, 10 to 40% of these patients will end up having what we call failed back syndrome, right? Because we've done surgery on the back and the surgery basically failed because they're back in the office with more back pain. We do a lot of fusions in the United States. We have higher fusion rates than other countries. And what's interesting is that we don't see the corresponding improvements in disability outcomes when we check for that. And then again, this is why it's controversial, right? Because in the US, the societies, the AANS and the CNS, recommend fusion as a treatment alternative for 1 or 2 level degenerative disc disease. But in the UK, for example, they recommend against fusion for chronic low back pain outside of clinical trials. And so you'll have that opinions are completely on both sides of the spectrum. And really, we haven't had a definitive paper or a definitive study that will say, oh yeah, 100%, if we do this, the back pain will go away.
So pretty much fusion is not a definite, is a 50-50 for back pain then.
Yeah, you know, again, it's a lot of nuance in asking the patient what type of pain are they having, and all this other and all these other things that we talk about when they have the clinic visit. But yeah, it's a very sort of a flip of a coin type of situation. I explain to my patients that if we're going to do fusion for low back pain, you know, they have to have the type of back pain that seems to get better with surgery. For example, it's called mechanical back pain, right? That it hurts their back when they're lying down. They don't have any back pain, but when they stand up, they start having terrible back pain, and slowly but surely the pain starts traveling down the leg. And you know that what's happening is that disc is basically incompetent, and when you stand and you load that disc, the disc will sort of slowly but surely crush the, when you load the disc, it'll get crushed and it'll expand and it'll start pushing on the nerves, which will give him the leg pain. And so to some extent, you know, the surgery for back pain that we do for that is also to treat that leg pain.
So other options then for back pain is?
I mean, obviously, like the slide says, given the drawbacks to surgical treatment and the controversy, a less invasive treatment option is desirable. And so this is what brings us to stem cells, right? We already learned how a disc is composed of different parts, right? You have the annulus fibrosus, which is around. You have the nucleus pulposus, which is inside. And that's what degenerates slowly but surely over time, or degenerates faster in some folks, depending on their genetic factors. And you have that now people are talking a lot about stem cells. And so what is, first of all, you start right at the beginning, right? So what is a stem cell, right? A stem cell, basically, we're all composed of stem cells, right? That's how life starts. When you're an embryo, you basically are, everything that's in there is a stem cell, and it'll develop into cell lineages, and these cell lineages will develop into organs and systems, right? And so as we develop and as we grow, we still retain some of those production centers, so to speak, for stem cells, right? Again, the 2 characteristics that a stem cell has to have: self-renewal, number 1, which it can divide and make more stem cells like itself, and it should be able to differentiate. In other words, it should be able to become a different cell. It can develop into different specialized cell types, right? And so what are the types, right? You have embryonic, which come for early embryos and can become any cell type. In fact, I think most of the stem cell therapy that's being conducted nowadays is from basically delivery byproducts.
Okay.
Before, the placenta, the amniotic fluid, and all these things used to go straight into the trash. And now it's biologic treasure, right? It becomes the raw material with which they'll produce and culture these cells and make them into a product to give to people. Right, you have the adult stem cells, like I was saying, are found in tissues like bone marrow, fat, skin, muscle, liver. Again, and again, these cell lineages will only make certain types of other cells. Right, you can't just put any type of stem cell somewhere and expect it to just regenerate whatever it is. Like, for example, if you have a bad knee cartilage, you can't just put a stem cell in there and you tell us like, okay, go make me a new cartilage for my knee so my knee doesn't hurt anymore. And the same thing with the back.
So what's the most common type of stem cell that they're using for back pain?
Yeah, so the primary stem cell types that are used to treat low back pain are mesenchymal stem cells, right? These are derived from tissues like bone marrow, which is the most common, adipose tissue, right, umbilical cord, allogeneic mesenchymal precursor cells, which means they're cultivated outside the body. And so, mesenchymal really is the answer, and you have all these different types that you can use to treat basically inflammation. So you do that, and then what are the results? I mean, what can we expect from a stem cell injection or a stem cell treatment? From the bone marrow and fat, when we take them from bone marrow and fat, they show pain reduction and functional improvement. But again, questionable results in the regeneration of tissues. And so basically what the stem cells end up doing, right, if you, let's say, you have some stem cells that either you got from the marketplace, from a trusted U.S. Compliant manufacturing place where they package these stem cells that they harvest at deliveries, where the mom consents to and the family consents to donate the tissue, and you can either inject that right into the let's say the knee, right, for example, and so what does that do, right? You have either that, or you have stem cells that were harvested from the patient himself or herself, where you have a bone marrow biopsy, so to speak, where they extract some bone marrow, they centrifuge the cells, and they basically re-inject them in whatever part of your body that you want treated. And so those particular cells will not, in turn, like, for example, if you have missing meniscus, they will not regenerate that missing meniscus. They basically will activate the stem cells that we have already in there to become a little bit more active, so that you can produce more anti-inflammatory molecules and in turn hurt less, right? Because that's the name of the game with stem cells. Basically, they will reactivate the stem cells that you already have. They'll make them have a higher metabolic rate, so to speak, and they'll produce more factors that will decrease the inflammatory response in the immediate vicinity. And you have that, for example, there's a lot of like PRP, they call it, right? Platelet-rich plasma. And so a lot of the treatments that are being sold to people have this PRP where they inject it on whatever body part that you need help with. And these don't have stem cells, but they have a lot of the factors that the stem cells will produce that will make inflammatory response a lot less in that particular body part, and therefore the pain will improve, and people can have months of improvement, right? there is some debate as to whether stem cells are just as good as steroids and, for example, knee injections. But, there's newer studies with these better products that are coming out where we see actual functional improvement stem cells as compared to, with stem cells as compared to steroids.
So I've always heard we already have stem cells in our disc space. Is that true that we have?
So yeah, it's funny because the inside of the disc, that nucleus part, right, is the oldest remnant of your embryologic development, right? So that's a remnant of, it's called a notochord. When you're forming as an embryo, there is this process called neurulation that will form this little tiny streak inside the little egg that's called the notochord, and around this notochord, everything in the embryo develops. The nucleus pulposus is basically the remnant of that notochord, and the cells inside the disc, they're not necessarily stem cells, but they act like stem cells. They basically stain like a stem cell. They have the two characteristics that all stem cells should have. But the only difference is that they only live inside the disc space. And so, there are some companies out there that are basically growing these cells in the lab. And there are studies in the US now that are taking place where they're actually injecting these, they're called disc progenitor cells, right? They're cells that are different from, like we talked about, the other types of stem cells. Like, they're different than the mesenchymal stem cells, for example. Why are they different? Well, there's been many studies where they actually inject these other stem cells, like the mesenchymal stem cells from fat tissue, or the mesenchymal stem cells from bone marrow, or the stem cells from the afterbirth products that are manufactured here in the U.S. by FDA compliant companies. And these cells will have an initial positive effect on the patient, but then you will not see any improvement in the actual state of the disc, right? If the disc is degenerated, they have these scores. They're called Furman scores. And so the worst are like the 4 and the 5, Furman score 4 and 5. And so when you look at the disc and you score it in the Furman scale, after the injection, the Furman scale will be the same. In other words, the disc will not improve. The disc itself, and therefore the cause of the pain, will not permanently improve. You will just decrease the inflammation temporarily, however that long that may be. Sometimes it's 6 months, sometimes it's less than that, sometimes it's more than that. And a recent study, basically medium and high doses of mesenchymal stem cells showed superiority over placebo through 36 months, right? But why is that? Because this disc space, right, that we have, like what I was saying, it's a very hostile environment. And so those stem cells are not used to that environment. They've never lived there. They've lived in oxygen-rich and a very non-stressful environments where they're not subjected to mechanical forces every day that you get up and start walking around. You're subjecting your discs to mechanical forces. And so some of these problems are not able to be survived by these cells. And so you'll see that the studies for these other types of stem cells will improve the pain, but they will not regenerate the disc, right?
So what back conditions are most commonly considered for like stem cell treatments?
Again, it's got to be degenerative disc disease. There is some work that's being done with the facet joints themselves, like for example, injecting stem cells inside the joints to again, you're not trying to restore the joint, you're trying to reduce inflammation, and you're trying to decrease pain. Really, that's the goal: decrease pain. Uh, Unfortunately, some of these things are still experimental, which means that insurance companies don't really pay for them. So they're all sort of cash type enterprises. And there are physicians out there that do it. I mean, in fact, here at OrthoSouth, at our spine institute, we have some of our pain management docs do some of this stem cell stuff, and it's very beneficial to a lot of people. Again, like we were talking about, the disc progenitor cell, right, that we have inside the disc space does exist, and it exists only inside the disc. It's similar to a mesenchymal stem cell, but again, it's already been primed to live in that area. And like I said, it's the oldest remnant of your embryologic development. So these cells are actually something special because they can survive in that environment, and they can produce all of these things in that environment without much nourishment and under the worst conditions imaginable. And so you see them in both the nucleus as well as in the annulus. These stem cells in the disc space can differentiate and participate in the regenerative process. And again, this is why degenerative disc disease happens, right? You have that with age, the number of these cells will progressively reduce. And since the intervertebral disc, like we talked about, is relatively avascular, it's hypoxic, and it's hypocellular, this makes it perhaps more prone to degenerative conditions. So that's why a lot of people have back pain, because this inside this disc space is the worst possible condition to have a cell survive. And so because the damage happens, people will develop discogenic pain, and it's again, you see it with degenerative disc disease.
What about current scientific studies? Is there anything out there about the effectiveness with the stem cells therapy for back pain?
Yeah,
where are we with that?
There are some. For example, look at this picture here. It shows all the types of stem cells that are inside the disc, right? This is a paper from Stem Cells, a publication called Stem Cells International from 2018, where they characterized all the types of stem cells or progenitor cells inside the disc and their location. And you have bone marrow derived stem cells, you have stem cell niche derived stem cells, you have cartilage end plate derived stem cells, you have nucleus pulposus derived stem cells, annulus fibrosus derived stem cells. You know, the nucleus, obviously pulposus derived stem cells, you can see them there in blue. The black ones are the cartilage stem cells, and you can see they're mostly in the end plate where you're supposed to have cartilage. And so again, this is, I believe, a very neat picture that shows you the population of cells sort of relative to the volume that you have there, and you can see that they're pretty scarce. You were asking about the studies. The latest human study with, again, allogeneic is just kind of a fancy word meaning that it's not yours. It was produced in a lab and you're just putting it in the patient. Allogeneic adult disc progenitor stem cell therapy was safe, was well tolerated, and significantly increased disc volume, right? So what we're doing is, what they're doing is they're isolating those disc progenitor cells, these that we talked about, not the mesenchymals, but the ones that are inside the disc, right? And they're making them into a product, and they're injecting them into people's discs. And they've found that it's safe, well tolerated. There's no rejection. There's no evidence of them producing malignancy or anything like that. And there's a significantly increased disc volume. So what it means is that these cells are not only helping you with the inflammatory issue that's causing the pain, but they're also actually regenerating the disc. Again, these are still preliminary studies, and this disc product or disc progenitor cell product is not approved by the FDA yet. So the high dose patients had clinically meaningful and statistically significant improvement in all of the pain scores. They have these subjective pain scores that they give patients the questionnaires to fill out, and they had improvement in all of them by 12 weeks. The clinical improvement was sustained at 6 months, a year, 1.5 years, and 2 years following a single intradiscal high volume injection of this adult disc progenitor stem cell. Again, if we were to look at the data, it would suggest that a high dose intradiscal cell therapy may be safe and effective treatment for symptomatic degenerative disc disease. And it's also producing, right, clinically meaningful results, as well as replenishing and regenerating the actual disc itself. And
So is this something that can be repeated, let's say after 2 years, if it wears off?
Well, that's still to be determined, right? We only have these studies with a single injection, because you want to try to make a study so that you can definitely say, yeah, this is definitely a benefit for the patient. Because if you start confounding your results with repeated injections, then you'll never know if the original injection worked, or if it was the second one, or does it have to be 3. And so the people that are doing this study are being very careful about it, which is a good thing. But again, what we see is that these progenitor cells demonstrate immunomodulatory and regenerative properties.
So what are the known risks or complications associated with these stem cell treatments for low back pain?
Very minimal, very minimal. I mean, it's hard to say, right? Because it'll depend who puts the injection in there, but the risks compared to surgery are very minimal. I mean, it's kind of like going in for an epidural steroid injection. It's a little procedure that they do, and then you just go home the same day. They probably don't even put you to sleep.
So you said, it's not FDA approved here in the US yet, but is it regulated at all?
Well, yeah, there's all kinds of ethical considerations, and there's a whole set of rules for us to expand on another a podcast. But yeah, I mean, there are a myriad of rules that we have to sort of go by if we're going to make this a therapy for the low back degenerative disc patient. And so yeah, I mean, it's highly regulated, and these studies have to be approved by the IRB board, and then when the FDA reviews the data, they're the ones that decide if this is going to be approved or for widespread use or not.
So I think your next slide kind of goes into this, but what's a realistic outcome that these patients should expect if they go with stem cell treatments?
So I would expect improvement, but I wouldn't expect to be 100%, right? If I was a patient that had this degenerative disc disease and a lot of back pain, if I get a stem cell injection, I wouldn't really expect much myself, because I'm a little bit of a skeptic. But for the general public out there, what I would say is that you have to expect some. I mean, there is going to be some pain relief, right? Because you have that they're injecting these substances, and these molecules in the stem cells really do have anti-inflammatory effects. And so it's been proven that inflammation is what's causing the pain. And so you can expect some pain relief. Again, depending on what product you're getting. I mean, obviously with this a disc progenitor cell situation, we have some regeneration. But as a rule, most products are not going to give you any of that regeneration. And again, results may vary, right? That's an honest assessment of somebody that's not trying to take you for a ride. I mean, if the physician really cares about the patient, they'll be honest about what the results are going to be, and results may vary really covers it, because some people may get 10% relief, some people may get 90% relief, sometimes 100, and most of the stuff is investigational, right? So insurance won't cover it. As we said before, you'll have just this situation where you have to go and pay for it.
Mm-hmm.
I mean, people pay thousands of dollars to take their pet to the vet, you know, and ICU, and the vet office is not cheap. This, you know, sort of probably mirrors the cost of that, probably less actually. So.
Okay. What advances do you see in the horizon for research for this?
So I think if the research continues to grow the way it's been growing in this field, we'll see results very quickly. And I would say in the next 5 to 10 years, we'll have several products probably that would be FDA approved and thereby paid for by insurance. And, you know, for us, we're spine surgeons, but really first and foremost, what we want is we want the patient to not have pain. And so if this gives us an alternative to treat the pain before we have to subject the patient to a big fusion surgery, like I showed the pictures with screws and rods and all of that, then, you know, it'll be like one more tool that we can have in our armamentarium to help the patient get rid of the pain that's crippling him. And really what we really want is, relieve the pain. We want the patient to return back to do the things that make the patient happy, right? We want them to go back to work. We want them to go back to their family without having this sort of hanging over their heads.
All right. My last question I have. So what's the single most important takeaway that you would tell someone who's considering stem cell therapy?
You know, I would say it's not going to kill you if you do it. I mean, it's not one of those things that people should be afraid of. I think that by and far, here in the United States, this is highly regulated, and it is very well organized. The scientific community and all of these organisms that the government has put in place, they coordinate all this stuff very, very, and they guard it very closely. And so if you go in to have a stem cell injection, for example, in Mexico, I can foresee you getting something that's not, or Brazil or India or wherever country you go to that's not highly regulated like the US, you know, I can't guarantee what you're going to get. But here in the United States, I can guarantee you that this is one of the things that you can try. And again, as the science behind all of this evolves and the results and the trials continue to improve, I would foresee this being a very viable form of treating back pain. Any questions from the public, Caitlin?
Yes, we do. We have a few. The first one I want to start with is from Miss Karen. She says, how long does the stem cells last? Or how long can the result last? And is it something you need to get repeated?
Well, there's some animal studies that, for example, for the repeat question, that have shown that a booster dose is possible, right? They're starting accelerated phase 3 studies leading to full possible commercialization. So this could be fully commercialized as soon as late 17 to or 27 to mid 28. But this is not an approved product in this country, right? So there's some companies out there that are hoping to be the first approved product that delivers stem cells into the disc in the U.S. And so, you know, these are the name of the company is called Dysgenics, and they've been sort of at the forefront of this progenitor disc cell science. You know, it's a very complicated molecular biology subject, but they've actually forged ahead, and they have pretty significant, very well verified scientific results. And so, again, we don't know yet whether you're going to need a booster or not, but it is possible. They've shown it in animal studies. The results are pretty well established. In other words, we said you have sustained clinical results even at 2 years with one single shot. And so,
Awesome. The next question I have is from T.S. Mitchell. How readily available are the mesenchymal stem cells to the general public?
those are available. The mesenchymal stem cells are available. I think those are the ones they do here. And so, again, it's just a type of stem cell, right? And then, for example, if they get some fat tissue from you, for example, that's a mesenchymal stem cell that they can harvest and they can inject it back into you. But again, like if you're gonna do stem cells, there's no. I mean, I've actually looked this up and sort of anticipation to this podcast. I haven't been able to find a study or a report that says that there's cancer that was developed after the injection of stem cells, because people will say, it's like, well, I want my own stem cells. But really, if you have degenerative disc disease, you're like a 60-year-old person, the inflammatory type of responses that you've endured are going to be much more than, for example, some cells that were harvested from a placenta, right? That were developed into a product that were sold to the person that's going to inject them in you. And so really what you're doing is you're trying to, again, regulate and boost your own stem cell population, right? And if you want to use your own, you can get mesenchymal stem cells from your bone marrow, you can get mesenchymal stem cells from your own fat, or you can get mesenchymal stem cells as a product from placenta, tissue, and afterbirth type stuff that gets donated.
Awesome. So just to clarify, one of the questions earlier on was that they're asking if stem cells are covered by original Medicare. And right now,
no, because again, it's one of those things that is still sort of labeled as investigational. So the FDA allows autologous same-day procedures, minimally manipulated tissue in homologous use, right? PRP, BMAC, bone marrow, aspirate, concentrate. And so all these things are approved by the FDA. Other products that are not approved by the FDA, like I said, you go somewhere else and I don't know what you're going to get.
All right, next question for you is, do stem cells help improve osteoporosis?
Lack of stem cells actually, activity can make osteoporosis worse. And so, stem cells are basically, like I said, the what made us in the beginning, and we have stores of them all over our body. But no, I mean, really, osteoporosis is sort of a different process that happens because of hormonal issues, because of activity issues, because of genetic issues. And so there are treatments for osteoporosis that are FDA approved that have nothing to do with stem cells, and you don't need to mess with stem cells if your main problem is osteoporosis.
Awesome. And the next question is, do you think stem cells can help with sciatica?
Again, sciatica, the sciatic nerve, people say sciatica, but really what it is the sciatic nerve is all of the nerves that are in your spine, like the bottom nerves, come out and get together and form that big cable called the sciatic nerve, right? It's the biggest nerve in your body, and it goes down through your butt area, and then it goes into your leg, and it divides into all of the areas it needs to go into. It doesn't mean that the sciatic nerve goes everywhere. It basically, all of the nerves that form that big cable basically divide afterwards after they pass that sciatic notch, and then they go wherever it is that they need to go. If sciatica is being caused by degenerative disc disease, right, that is pressing on the nerve, if we restore the disc height and all those things, yeah, maybe it can help. But really, sciatica is more of a nerve compression problem rather than a degenerative disc disease back pain problem. So again, like I was saying, there's some things that are well treated with surgery, and sciatica is one of them, especially when we can see the nerve compression on the MRI, for example.
Awesome. And another question is, are there stem cell studies that you can sign up for?
I'm sure there are. I'm not aware of any one study that we have here at OrthoSouth. When I was working at my other place, there actually was a study that we were recruiting for to see if we could inject some of these patients with these progenitor disc cells.
All right. Any remarks on stem cells, on spine care, or anything like that before we end?
But no, I just wanted to explain the anatomy of the disc and what is a stem cell and how would stem cells help anybody that is having pain. Because again, stem cells are not only used for low back pain, for example, they're used for knee pain, they're used for hip pain, shoulder pain, elbow pain. They basically sell you on the stem cells. And again, if it's in the US, I do think that some of these treatments give good results. And you can see it in the computer if you log into the PubMed site that the government has. You can type in whichever type of study you want to see. So you could just type stem cells for knee pain, and all the scientific studies that have been published up to date will pop up, and you can sort of research on your own with real scientific papers what are the outcomes of these treatments. And again, because the stem cells, we're talking about inflammation, right? Because the stem cells help that inflammation, help reduce that inflammation, you can expect them to be effective in as much as you're having inflammation in your knee, right? If you basically have a non-existent joint with terrible arthritis and you probably need a knee replacement, but if you're just having knee pain with some mild degeneration, I think that's where the real use for stem cells come in.
Awesome. Well, I'm excited to see what the future holds for stem cells over the next couple of years, and hopefully we get to use it more and more in medicine. But thank you guys both for being here. Thank you.
Thanks for having us.
Yeah, of course. Thank you everybody for watching at home. Sorry for the technical difficulties at the beginning, but we're glad you were on here. And you'll see all of the video footage on all of the platforms afterwards.
It was Bonnie's fault.
Everything's my fault.
Don't blame her. Well, thank you all for watching. And if you'd like to make an appointment with either of these doctors, or if you have any questions, our information will be shown in just a moment.
We'll be happy to see you.